Alright, so now we are going to go over the stages of labor and delivery as far as the pre-hospital side of it goes. Alright, so stages of labor. First stage, we know there's 3 stages, right? So the first stage is going to begin with the onset of labor pains, and it's going to last until the cervix is fully dilated. Now usually that amniotic sac is going to rupture near the end of this stage, but there's actually some more stuff that's happening kind of in between here, and oftentimes the early stages of labor kind of may go unnoticed, especially if this is their first pregnancy. And keep in mind too that the length for each stage, the first, second, and third, really depends on if this is their first pregnancy or, you know, how many deliveries they've had before. Typically, the more deliveries they've had, the faster they go through these stages. Alright, so the first stage is of labor. Relief of pressure in that upper abdomen. So this is when the baby starts to drop down, lower down. This is called lightening. Right, they may have an increase of pressure in the pelvic area. They may have what's called a bloody show. This is where like that plug of mucus that is literally like plugging up the cervix, which is sometimes mixed with blood, and that's okay, is discharged from the vagina. They may or may not notice this. Alright, then they'll have the onset of actual labor pains. Typically these early contractions are going to come somewhere between 5 and 15 minute intervals. In this latent phase, the cervix is going to start to dilate and efface, which just means get thinner. Alright, the lower segment of the uterus is pulled upward over the presenting part, which is what's going to thin out that cervix. And it's going to stretch until it's wide enough to accommodate the fetus, which is really pretty cool. It goes from like really tight, closed up to about 10 or so centimeters, about the size of a cantaloupe or so. Alright, and this first stage of labor lasts until that cervix is fully dilated. Typically around 12 hours if this is their first birth, and could be, you know, up to 8 or so if they've had multiple births before. And like I said, amniotic sac usually is going to rupture towards the end of this, and this is where it's like, oh, hey, we're for real in labor. Alright, second stage is going to start as the head of the fetus descends and flexes to enter into the birth canal. And it will undergo, the fetus will undergo several positional changes as it passes through this birth canal to actually get out. Alright, the first position is going to be an internal rotation. So the head is going to rotate, well, should rotate with the face towards the rectum. The woman's rectum, not the fetus's. Alright, then the third position is going to be extension. And so this is where the fetus is kind of tilted, so the crown of the head is seen at the vaginal opening. We see this as crowning. Alright, and then we're going to have rotation of the head to the side to align it with the shoulders. And then the final position is going to be rotation of the shoulders that's going to have to actually help expose the fetus from the vagina. Alright, at this point contractions are getting more intense and more frequently, usually 2 to 3 minutes apart. Alright, the cervix fully dilated, fully effaced, and delivery is imminent. Okay, the second stage of labor is going to conclude when the newborn is fully delivered. This could be 1 to 2 hours in a new first-time birth. This could be about 30 minutes in a multi-para. You know, if they've delivered multiple times. Now keep in mind too, where we're coming in, where this rotation and extension and stuff is starting to occur usually before we get to them. When we think actual delivery, we're at this crowning stage, these last third and fourth positions there. And then finally the third stage is where the placenta separates from the uterine wall and is expelled as well. Alright, you're going to have uterine contractions that are going to squeeze close the exposed blood vessels from that placenta came off, because it's kind of like a big bloody scab. It leaves an open wound basically in the uterus. And so these uterine contractions are going to help slow it down or constrict and close that bleeding down. This is why it's very important to palpate the fundus after delivery of the placenta to see if we've got a boggy uterus, which is kind of like loose, or if we've got a firm uterus, which is what we want, because if we don't have a good firm uterus, if we've got a boggy uterus, then we know that the increased likelihood of postpartum hemorrhage go up substantially. Now, let's talk about responses to labor, okay? During labor, the maternal responses, you're going to have an increased workload of the heart. You're going to have increased blood pressure, increased pulse, increased cardiac output, increased breathing rate. Alright, this is both due to pain and to accommodate the increased oxygen demand. Mama is doing some work. You're going to have increased white blood cell production due to responsive stress of labor. Alright, the renal system is going to help preserve fluids and electrolytes, so the urge to urinate is going to go down a little bit. Keep that in mind though, that as that baby comes through, it's going to pass between the bladder and the rectum. If there's anything already in the bladder or the rectum, it's going to come out. is going to get compressed and it's probably going to come out. It is what it is. Throw a towel down, keep on trucking. Okay, they're going to have some protein breakdown and increased temperature from the literal physical exertion of it. All right, blood flow is diverted from the GI system, so delayed stomach emptying. They may have some loose bowel movements. Nausea, vomiting, diarrhea are all possibilities. All right, the fetal responses. So with this is going to be from that real powerful uterine contractions. It's going to decrease the amount of oxygen and nutrients to the fetus. It's going to not remove as much waste product from the fetus. It's going to have a decreased fetal heart rate. And it could lead to fetal acidosis. This is why if we have a prolonged labor, we want to be very careful and recognize that that is a potential problem or potential emergency state for that fetus because of all these things that are occurring. In a short time span, the fetus can deal with it. You know, it's getting evicted basically. But if this prolongs, then that's when it could cause some problems. This is why we say if we are laboring for more than about 20 minutes and we have not birthed yet, then we need to go on and start headed to the hospital because of this fetal response to the labor. So let's talk birthing positions, okay? If the birthing is taking place in their home, they're usually going to be lying supine on their bed or some other flat surface. Now, this is going to be much easier for us, but a lot harder for the woman because they're having to push against gravity. Right? They may prefer sitting on the edge of a chair, squatting, or something like that for delivery. Some may want to be in a tub, things like that. All right, these alternative pushing positions are becoming a lot more popular than they used to be. We're going to work with them the best that we can. As long as we can still have a safe place and a safe way to do this, then we're going to try to accommodate them the best that we can. Notice how in this picture here, like she's got some chairs there for the feet and she's kind of on the edge of something where she can kind of sit a little bit more than like on a bed. That may be a good idea. Just be careful. If you got nothing down here, babies come out, they're slippery. You don't want to drop the baby. All right. So the standing birth. With this gives them a lot more movement to move, a lot more freedom to move up until the point of delivery. Gravity helps. The fetal heads moved away from the sacrum when they arch their back, so that in theory should make it a little bit easier. They may prefer this. All right, gonna be a little bit more difficult for us. Semi-Fowler's position. This is where they're propped up in like that high Fowler's or semi-Fowler's position, and this may help because they can kind of lay back to rest between contractions, but they've got that little bit of gravity on their side when they're actually pushing. You may require somebody to help hold them up between these, during these contractions as well, though, here. That would be a great job for their partner. Some more birthing positions, the kneeling birth. This is where they kneel, their butt up in the air, resting on their elbows. Some of the same advantages as squatting. They can arch their back to help assist with the delivery. The fetal head can move away from the sacrum. Got a little bit of gravity helping them out there. A lot of people will use this in a water birth. And then your sideline position. This is a left Sims position. The upper torso is supported with pillows. It ensures the uterus and the fetus are moved away from the inferior aorta. It helps, they say that there's less perianal tears with this method, so, maybe some pros and cons there as well. So let's talk preparation for delivery. First thing, open the OB kit, right? Wash your hands. If for some reason you cannot wash your hands, use a copious amount of hand sanitizer. Clean your hands the best that you absolutely can. All right, put on your gloves. Now, if you are putting on sterile gloves, you are not going to put on sterile gloves until you are ready to go, because once you put on sterile gloves and leave your sterile field, it's no longer sterile. All right. When you're opening up the sterile OB kit, maintain your sterility by opening the outside, touching the outside only. Wash your hands thoroughly, put on your sterile gloves, and then standard precautions. Use your sterile gown, your surgical mask, your eye protection. If you do not have sterile gloves that will fit you, then you wear clean gloves and you only touch your OB kit stuff. You have to have your partner hand you other things. You cannot touch or move or do anything else with those. We want to keep them as clean as possible. At this point, we're not really so much worried about us getting an infection thing, but we're worried about bringing something to that newborn that has a very minimal immune system at this point. Okay, so if possible, we're going to drape the woman in sterile towels from the OB kit, those little drapery things. We'll place the first towel beneath their buttocks. If you've seen my videos or done anything with me on this, I'm a big fan of putting a towel down first, like an absorbent towel, then putting the sterile towels on top, because a whole lot of stuff will come out of there. All right. Then you can lay that second sterile towel flat between the legs, just below the vaginal opening. And then you can drape a sterile towel on their abdomen and on each thigh. Now, with that said, a safe and controlled delivery is going to take precedence over draping. So if this is one of those, hey, there's a baby head, oh, here we go, we're about ready to catch, don't drape, okay? You're going to clean. You should have 2 wipes, and you will wipe one wipe down the side of vagina, down the labia, so top to bottom, starting by the clitoris, wipe down with the wipe, toss it. Open up the other wipe, start on the other labia by the clitoris, wipe down, throw away. Alright, only top to bottom, 1 wipe each, no back and forth or anything like that, straight down. This is what we want to do if we have time for nothing else. That's one thing we want to do, try to create as clean of an area as possible. Alright, make sure that you don't forget to attend to the emotional needs of the patient, okay, their partner, because that's going to be a big thing too. You know, maybe they had this whole thing planned to be in the hospital and now things are not going as planned. Alright, so try to have your partner, or better yet, their partner, at their head up there, helping keep them calm, help them with oxygen if needed, emesis basin, suction available if needed. You know, if you have time, start an IV, put them on an EKG monitor. If they're hypotensive, consider a fluid bolus. All these things if we have time to do so. If not, we're going to clean and catch and then do these things. But ideally, we have time to do these things, okay? Try to encourage the woman to rest between the contractions, and don't bear down until they can assist with delivery, until you can assist with delivery, and until they're actually having a contraction. If they're pushing when they're not having a contraction, they're just squeezing for the sake of squeezing. They're only going to move and progress along when they're having that actual uterine contraction, so that uterus is actually bearing down and squeezing with them. Alright, so keep in mind, I'd like to point this out here at this point, this is not an emergency. Normal childbirth, not an emergency. It happens. That happens every day, multiple times a day. That's how every one of us that's listening to this got here. Alright, so our job is to assist. Mama is doing all the hard work. We're there to assist, okay? We're going to try to help control the delivery. When that crown begins, when that head comes out, put gentle pressure, just kind of put your hand up there on the head to prevent it from just popping out and causing tearing. Alright, then support the head as it comes out from the vagina and starts to turn. Do not try to pull the newborn out. Alright, if the membrane is still covering the baby, the newborn's head, you're going to have to tear the amniotic sac with your fingers or forceps so they can breathe. Okay, it's just a light little pinch with your thumb and forefinger should rip the amniotic sac if it's still intact. Okay, and some fluid's probably going to come out. All right, then once the head has come out, we're going to take your middle finger and feel alongside the head to feel for a nuchal cord. Why the middle finger is the longest usually, that's why. All right, cord compression can occur if it's around there, which can cause a slowed fetal heart rate and fetal distress. If you have a nuchal cord, typically it's going to be kind of loose. We're going to take it and gently try to slip it over the head and the neck. If it is wrapped tightly around the neck where you can't do that, we're going to put 2 umbilical clamps about 2 inches or so apart and cut between the clamps very, very carefully. Okay, always cutting away from the infant, not towards. Alright, now, as far as the airway suctioning, so the current AHA guidelines as of 2021, the current AHA guidelines say only suction if it's needed. Alright, now with that said, if it's needed, we only suction with bulb syringe. We do not use electronic or any kind of suctional like that on a newborn because you can cause barotrauma. Alright, you only are going to use a bulb syringe that comes in the OB kit. With that said, the current AHA position is that if they have a minimal amount of fluid in their mouth or nose, they can clear that. Okay, we're more likely to cause harm by aggressively suctioning than just letting them deal with it. If they have meconium staining, if they're showing signs of respiratory distress, then we're going to go ahead and suction them. Alright, we're going to gently guide that head downward to help that upper shoulder deliver, because it's going to come underneath the pubic symphysis. Okay, then we're going to guide the head upward to allow the delivery of the lower shoulder. Now, once these 2 shoulders are out, the trunk and the legs are going to come out pretty fast after that. Okay, so make sure you hold on to that newborn as it comes out. It's going to be wet, it's going to be slippery. Alright, hold on to them. Now, once the newborn is delivered, we're going to maintain that newborn at the same level as the vagina. Alright, we're going to wipe any blood or mucus from the nose and the mouth, little sterile gauze there. Alright, suction if we need to. If we do need to suction, we squeeze that bulb before we insert the tip, and we put the tip in the mouth or the nose and release slowly, withdraw the bulb, and then expel into a waste container. Repeat as necessary. Okay, Now we're going to dry the newborn with sterile towels, and we're going to wrap it up in a dry blanket. We're going to record the time of birth. Oh, I totally skipped a step there, didn't I? So what are we going to do? What did I skip? If you said cutting the cord, you were absolutely right. So at this point, and their AHA's current practice again is delayed cord clamping. That's all I was doing, just delaying. So delayed cord clamping. So about 30-60 seconds after birth, that's when we're looking after we've dried, kind of wrapped them, dried them up with the sterile towels. Now we're going to take and we're going to clamp. And so we're going to clamp about 5 centimeters, a couple inches. If you're not sure on the measurements, put your fist by their abdomen, clamp on the top of your fist, then another fist, and then another clamp. Clamp really good. That cord is really fibrous and thick, and it's a lot harder to clamp than you would think it would be. But once it's clamped, then we're going to palpate the cord in between the clamps and make sure we don't feel a pulse. If we feel a pulse, the clamp's not good enough, and we got to clamp again. Alright, if you've got hemostats, clean sterile hemostats, you can use those. If not, open up a kit, get another set of OB clamps. Alright, then we are going to, once we no longer have a pulse there, we're going to cut. Okay, we're going to clamp and cut. Then once we are cut, now we're going to wrap the newborn in a dry blanket. We should have already recorded that time of birth for our patient care report. Remember, now you've got 2 patients, so 2 PCRs. Fun, right? We're going to get our APGAR. Alright, and so this is just going to be that initial vital function here. The heart rate. Alright, we're going to look at the respiratory effort, muscle tone, reflex irritability, and their color. Most newborns are going to have a 7 to 10 score. If they have a score of 4 to 6 or so, they're probably going to need some resuscitation. Oh, there's the cord. It just got a little out of order. Alright, but make sure, once you do get it cut, make sure that the ends, there's not any bleeding or anything like that. If there is some bleeding on the end attached to the newborn, make sure you clamp again proximal to that first clamp. Do not remove the first clamp though. Kind of like tourniquet, add another one, don't remove the first one. Alright, if mom is stable, then we can give baby to her, allow for chest-to-chest, skin-to-skin contact, breastfeeding, attempt to breastfeed anyways. They may or may not do it, probably won't, but attempt to breastfeed. The good thing about the attempting to breastfeed, that nipple stimulation will release oxytocin or pitocin, and it will help stimulate the contractions for the uterus to dispel the placenta, and then ultimately constrict and contract and slow any postpartum hemorrhage as well. Alright. Now, with the placenta delivery, we're not going to wait for the placenta to deliver, okay? It usually is going to deliver within 30 minutes after the newborn is delivered. Don't pull on the cord. We're not going to speed this up. You can cause a whole host of problems. You can cause uterine inversion. You can cause hemorrhage. We don't want any of that, okay? If they do have to just deliver the placenta, they're probably going to do it en route. They'll feel the urge. The contractions will start back up again. And the uterus will kind of come up top in the abdomen and feel kind of hard when it's palpated, and the cord will start to lengthen, and then here comes the placenta. You may have a little bit of blood with it as well. So when it comes out, it should be, the fetal side should be kind of a gray, shiny, smooth looking thing. The maternal side will be like a dark maroon and probably have a rough texture. Take a little look at it. Look to see if there's any lacerations, any chunks missing, anything like that, and that'll let you know if there's anything left behind. Just report your findings to whoever you turn over care to at the hospital. Okay. Examine the perineum for any lacerations. If you have any lacerations, you can apply light pressure on any bleeding areas. You can clean up the patient as able, place a sanitary pad over the vaginal opening, and transport. So the placenta typically is going to go in a red bag and just be transported with the mama and the baby. Now, important thing to keep in mind. Mama does not need to hold the baby on the way to the hospital, and that sounds crazy, right? Because that's what I was taught to do once upon a time. What's the problem if you get in a wreck on the way to the hospital? That baby's going to go flying like a little slippery football. Alright, so we need to try to have a car seat for the newborn and place the newborn in that car seat and then cover them up and keep them warm. Alright, you don't want to put them in the car seat wrapped up in a blanket because then they could slip out. But we want to put them in the car seat, and then we want to cover them up and keep them nice and warm if at all possible during the actual transport to the hospital. So, after delivery, alright, we're going to obtain mama's vital signs. We're going to just give mama a good watch. Be very, very careful and monitor closely for any signs of hemorrhage or shock. Remember, small increases in blood and heart rate, small decreases in blood pressure should throw up some warning flags, okay? Any respiratory difficulty should throw up a red flag. It's not common, but they can have an amniotic fluid pulmonary embolism, basically. Alright, we're going to assess the fundus. It should be firm on palpation. If it is not firm, if it's boggy, if it's squishy, all right, and they've delivered the placenta, then we're going to do a fundal massage. All right, we're going to note any lochia, which is just the vaginal discharge of blood and mucus following delivery. Usually it's red the first couple of days, decreasing and changing to kind of a brownish color after delivery. All right, and then we're going to cover it with blankets and just basically treat her for shock, and then transport to an appropriate facility.